So welcome all to the step-in session on mechanical ventilation, modes and alarms. Greetings from Ludhiana. I am Dr. Puneet Chopra from SPS Hospital, Ludhiana, and our speaker is Dr. Gunchan Paul. Dr. Gunchan Paul is Professor Critical Care Medicine at Dayanand Medical College, Ludhiana. She is chairperson of Ludhiana branch of ISCCM, and she is member ISCCM Research Committee, and she has many publications in national and international journal. So this topic, mechanical ventilation, is very relevant topic because every day we deal with these patients and it is very important to understand the basic modes and alarms. So this will be a practical session, and if participants have any questions, they can write it in the chat box and we can discuss during the session and after the session. So over to you, ma'am.
Thank you, Dr. Puneet, for the kind introduction. Good afternoon, everybody. We'll be talking about mechanical ventilation. As Dr. Puneet said, this should be an interactive session. Wherever you have a problem, you can raise your hand and we can discuss in between also. So I'll be discussing about something about the basics. What are the indications? What are the initial settings of the basic modes? And what are the alarms we should know to prevent any complications? So coming to the evolution of mechanical ventilation, initially the ventilators, you can see these were iron lung ventilators. Patient was put inside the chamber and negative pressure was created outside, as normal is negative pressure breathing. So it was thought that if we create pressure outside and suck the chest, like the pleural cavity has negative pressure, we can expand the lung. And this was huge ventilators. So it was thought, it was usually a last resort to ventilation because ventilators were not that developed. And it was thought that it was actually a potentially harmful therapy. And pre-terminal illness, does say, if nothing is going to happen, put the patient on ventilator maybe. And such ventilators were used in polio epidemic, they were massively used. But now we have very sophisticated, computerized, user-friendly ventilators with lot of modes and lot of alarms. And that is the beauty of these ventilators, because any change which occurs in when you are ventilation, there are alarms and there is change in the graphics. So you come to know whatever you want to deliver is being delivered or not. So they're extremely useful. But remember, mechanical ventilation is a supportive mode of therapy. It is not a treatment for something. Major surgeries are nowadays possible because of this ventilation, which is possible, and also for acute and chronic respiratory disease. So it gives you time till the basic pathology heals. So how can we describe mechanical ventilation? Actually, mechanical ventilation is a technique in which energy is supplied in a predetermined way to replace the effort or the work done by the muscles of the patient. So role of mechanical ventilation is supportive till the primary disease heals. So I can say, if I give the control of breathing from my neurons to the neuronal chips, to the microchips of the computer of the ventilator, and the work of breathing instead of the muscles is done by the machine, that is what is mechanical ventilation. So just a question here in the beginning to just to know how much you understand about the mechanical ventilation. Which statement does not describe positive pressure ventilation? It requires an artificial airway, 1. B, it is applied to outside of the body. C, most similar to physiological ventilation. D, most frequently used with critically ill patients. E, used at home for neuromuscular and nervous system disorders. So you can give your answers in the chat box. Which does not describe positive pressure ventilation?
So participants can write in the chat box.
Are there any answers?
No, no one has answered till now.
It is a simple question, which does not describe. When we are talking of positive pressure ventilation, we use an artificial airway. We use an endotracheal tube or a mask. Is it applied outside to the body? Yes. Is it similar to physiological ventilation? No. Normal physiological ventilation is negative pressure ventilation. So this we are talking about invasive ventilation. It is positive pressure ventilation. It is used in critically ill patients, and if we are talking of NIV, can be used for neuromuscular and nervous system disorders outside. Someone has raised their hand.
Swanpura has raised her hand.
You can write the question in the chat box, please. So till then, we continue. So mechanical ventilation can be...
Many people have answered C.
Yes, that
Two people
is
have
very
answered
good.
C. Yes.
That is good. That is not, because mechanical ventilation is positive pressure ventilation and normal physiological ventilation is negative pressure ventilation. That is very good. So when we are talking, if we give it through an NIV, apply a mask, it is non-invasive ventilation. But the NIV has problem of leaks, the problem of patient compliance. So if we want a more secure method of giving positive pressure ventilation, we put in an artificial airway or an endotracheal tube and we ventilate the patient. So what are the indications? Why do we need to put the patient on mechanical ventilation? The first and the foremost indication is respiratory failure. So respiratory failure is of two types. It is ventilatory failure or hypoxemic failure. When I'm talking of ventilatory failure, I mean to say that if this room is well ventilated, it means all the bad gases are moving out. So ventilatory failure, I'm talking of carbon dioxide. When the lung, as a machine, is not moving, as a pump is not moving, carbon dioxide is collecting, there is hypercarbia, so there is ventilatory failure. While on the other hand, if the lung parenchyma has a problem, we call it hypoxemic failure. So there are two types of respiratory failure. For both, we can use mechanical ventilation. We also use mechanical ventilation to support vital organs in patient of multi-organ dysfunction syndrome, like a patient of septic shock. So septic shock, patient is in sepsis, his BP is low, and he's breathing very fast. So we give him mechanical ventilation to support other organs of the body and to reduce the respiratory work. So similarly, in patients of cardiac insufficiency, supporting respiratory system in such patients will reduce the demand on the heart and allow them to recover. We will eliminate the work of breathing done by the patient, and we will reduce the oxygen consumption, because patient is breathing tachypneic, he's breathing very fast, he's using all his energy in breathing. So if we sedate and put him on mechanical ventilation, his oxygen requirement will decrease, the cardiac will also get offload. So in patients of cardiac insufficiency, also mechanical ventilation is given. Thirdly, it can be given in patients of neurological dysfunction. A patient comes with a drug overdose, a patient of head trauma who is not breathing, who has low respiratory rate or a low GCS, a case of poisoning. So there, to protect the airway, we also give mechanical ventilation. So it is basically given in cases of respiratory failure, but also in cases of cardiac insufficiency and neurological dysfunction, mechanical ventilation is helpful. So there are two underlying basic problems for which mechanical ventilation, how will it work? How will it improve oxygen or wash off carbon dioxide? There is something called as dead space ventilation. So see, these are normal alveoli, and this is the normal gas arteries and veins around it where gas exchanges occur. So if this supply, there's an arterial occlusion and the the blood flow is cut off. So the lungs are being ventilated, but there is no blood flow. So there will be no gas exchange. So this we call what is called as dead space ventilation. This is when the alveolar areas which are ventilated but are not perfused, they are described as dead space. The ventilation is there, but that space has become dead because it is not contributing to gas exchange. The second problem in the lung can be shunting. Shunting means, see, these are normal alveoli and there is blood around them, their gas exchange will occur. If the alveoli gets collapsed, there is fluid outside or something is collected inside the alveoli. Like if it is filled with pus, which we call as pneumonia, if it is filled with water and protein like ARDS, if it is filled with water like congestive heart failure, or blood which we call hemorrhage. So alveolus is not perfused, the blood is around, it is perfused, but it is not ventilated because either it is blocked or it is collapsed. Again, then it will not take part in gas exchange and there will be hypoxia. So this is called as shunting. So there are two disease problems which are going on: dead space ventilation or shunting of blood. This blood is coming and going around this, but it is not getting any oxygen. So this we call as shunting of blood. These are the two problems on which mechanical ventilation will work and correct them for patient improvement. So in the lungs, dead space is happening or shunting is happening. But how do you come to know? What are the clinical parameters which tell us that the patient should be put on mechanical ventilation? So clinically, either the respiratory rate is very high or it is very low. As I told in neurological patients who are a patient of head injury, poisonings, drug overdose, he's not breathing, rate is very low or very high, or he's breathing at a very shallow tidal volume. Tidal volume is not adequate. He is gasping breathing. Breathing is ineffective. There are signs of fatigue and exhaustion, which starts with mental deterioration. Patient is restless. Sometimes it is only because of hypoxia. He's sweating. He's throwing out your IV lines, pulling out your ILS tube because he's restless, because he's hypoxic. So these are signs of impending respiratory failure. And if you have an ABG, then on the ABG, you can remember a rough idea. PO2 less than 50 and PCO2 more than 50 at an FiO2 of 60%. Both of them indicate that either there is hypoxia or hypercarbia and the patient needs some assistance, either in the form of NIV or a mechanical invasive ventilation. So we are basically going to discuss about invasive mechanical ventilation. So what is a mechanical ventilator? What are the components? It has an oxygen supply and an air supply. High pressurized, which we get from the gas pipeline, and they are blended together because all patients, we are not giving 100% oxygen. So this is blended, and then there are valves which will give open and the gas will go to the patient during inspiration. Then the valve will close and expiration will happen. You must know that expiration is always a passive procedure. While in positive pressure, we are going to give gas with pressure inside the lung with inspiration. During expiration, no, the ventilator is not working. Only the expiratory valve will open. No gas will flow from the ventilator, but gases will flow passively from the patient. So it is all patient dependent. The expiration is patient dependent. The ventilator does not work during expiration. It is a passive procedure. And then there is a circuit which connects to the patient. So there are high pressurized gas source which contain air and oxygen, a blender, inspiratory and expiratory valves, controls of these valves, pressurized air delivery system, and a monitor and alarms, which are the interface where you come to know what you are delivering is being given to the patient. So we'll talk of first the key terminologies, and then we'll talk in what modes how do we set them. So first thing we need to set is something which is called as tidal volume. That is the amount of gas which will go with each breath is called the tidal volume. So we set it at now this tidal volume is according to the predictive body weight of the patient, because in obese patients, the lung will not increase in size with increase in weight. So it is according to the predictive body weight, means according to the height of the patient. The predictive body weight is calculated with a given formula. So you can roughly remember for a 60-65 kg patient, we want to give 6 ml per kg of gas. So that comes out to be roughly 360 to 400 ml. So if you want to initiate ventilation and you want to set the tidal volume, around 360, 400 to 450 is adequate for a normal adult patient. Initially 10 ml tidal volumes were used, but now it is thought that with this high tidal volume, it can cause trauma to the lung. If we give more tidal volume, we have to give more time for that time to deliver, and that will lead to higher pressures. So tidal volume which we want to give to the patient is roughly between 6 to 8 ml per kg of the predictive body weight. The second thing we need to set is the respiratory rate, because it is a very important component, respiratory rate and tidal volume. Now tidal volume is the amount of gas with each breath and multiplied by the number of breaths in each minute. That will give us the minute ventilation. Volume in each breath into the times it is given in 1 minute becomes the minute ventilation. Excuse me. Again, if the rate is very high, then the time for that 400 volume to go will be very less. So again, the peak pressures will increase. So we should keep at least a normal rate when we initiate ventilation about 12 to 14 per minute. If we do not keep that, we keep it lower side, then that will result in hypoventilation. PCO2 will increase. So how to find out the required minute ventilation? So if I say a normal patient with 400 tidal volume and 15 respiratory rate, that comes to around 400 into 15 is about 6,000. That is 6 liters. So normal adequate minute ventilation is about 6 to 8. Is my adequate minute ventilation. So if a patient has a PCO2 of 50, the tidal volume is 500, his respiratory rate was 12. So I want to increase the respiratory rate. How do I calculate? Tidal volume is 500, but I now want it to become 40. So rate into tidal volume into PCO2 is equal to the new respiratory rate which I want to calculate into again the tidal volume 500 into 40 which I desire. So this comes out to be 15. So if I increase my respiratory rate from 12 to 15, so my carbon dioxide will come down from 50 to 40. So rate into tidal volume into PCO2, equate on both the sides. So that will give you a rough idea. That is a rough idea to calculate how much rate you want to increase to decrease the PCO2. And carbon dioxide gets washed very fast. So when you've made the changes, half an hour or 1 hour down the line, you do a repeat ABG, you can see your carbon dioxide has decreased. Now, third thing is IE ratio. That is inspiratory to expiratory time. So normal it is 1:2. I told you expiration has longer time because it is a passive procedure. During inspiration, gas is being forced. During expiration, gas will passively come out from the lungs towards the ventilator. So if I kept a respiratory rate of 20, so 60 divided by 20, that means 3 seconds per cycle for each breath. And I've kept a ratio 1:2. It means 1 second will be inspiration and 2 seconds will be expiration. So you should keep it at an acceptable rate, 1:1:1.5 or 2, which is normal, maximal suitable to the brain because it is close to normal. Now, this is the fourth key component, that is PEEP. That stands for positive end expiratory pressure. So normal we keep a physiological PEEP of 4 to 5 centimeters. And because there is PEEP, it will increase the intrathoracic pressure. So there is always a risk of hypotension with PEEP. And because the pressures can increase, and if they go beyond a certain level, they can cause injury to the lungs. Barotrauma is also a risk. So start with a PEEP of not more than 6 to 8 centimeters of water. So these are different terms which are used for PEEP. Similar to PEEP, that is CPAP, continuous positive airway pressure, but it is a mode of ventilation. When we call it EPAP, expiratory positive airway pressure, that is in NIV, and when it is with invasive ventilation, we call it positive end expiratory pressure. So these are all terms used for positive pressure during expiration. During CPAP, it is a mode, which we'll be talking about in our next slides. EPAP is the term used for NIV, and when we are giving it with an endotracheal tube invasive ventilation, we call it PEEP. So another question, which of the following is a risk of keeping high PEEP?
So you can put the answer in chat box.
What dangers, what can occur when you have to be vigilant of what factor when you keep high PEEP? Hypertension, hypotension, hypoxia, all or none?
One has typed hypotension. The Sinai Sijo has typed hypotension.
Very good. That means when we are keeping high PEEP, our intrathoracic pressure increases. So there is a risk of causing hypotension. Hypoxia, rather we are treating hypoxia by giving high PEEP, and hypertension does not usually occur. So the last terminology is FiO2, that is fraction of inspired oxygen. Because oxygen is also a gas. In COVID, we have seen how valuable oxygen is. So we should not waste it also and think it is a drug. It should not be, oxygen toxicity should also not occur. So 100% should not come on the monitor. Anything above 94, 95 is well acceptable for any patient. So you should keep the FiO2 be minimum for an acceptable SpO2. So 100% is required only when we are doing suctioning, when we are intubated the patient, or at times of extubation, tube exchange during procedures, so that any hypoxia does not occur during the procedure. Otherwise, your FiO2 should be minimal so that you get an adequate saturation above 92 to 94%. So when we are mechanical ventilating, our target is to keep a PA2 of 60 to 100, PCO2 between 35 to 40, these are the normal values, pH between 7.35 to 4.5, normotensive, because when I'm giving PEEP, I am worried about hypotension. A well-perfused patient, lactate should be less. Patient on ventilation, but with no sedation, minimal sedation, conscious, cooperative, and the peak pressure should be less than 40 centimeters. So what are the ventilatory parameters I need to adjust when I need to maintain an adequate minute ventilation? So if the PCO2 of the patient is rising and the minute ventilation, if I think it is low, I want to adjust it. What parameters will I adjust? Will I adjust PEEP and FiO2? Or I'll adjust PEEP and respiratory rate? Or I'll adjust respiratory rate and tidal volume? Or I'll adjust FiO2 and tidal volume to maintain an adequate minute ventilation. This is not difficult. I've just talked about it, that when we want to maintain an adequate minute ventilation is amount of gas exchanged in 1 minute. So what factors will I need to adjust to maintain an adequate ventilation?
No answer till now.
No answer. Minute ventilation means amount of gas exchanged in 1 minute. So in 1 minute, each breath, it is tidal volume, and number of times it is respiratory rate. So tidal volume and respiratory rate are adjusted to maintain minute ventilation. These are the basics. If you understand this, then it will be easy for you to understand the mechanical ventilator, what it is doing. And what are the ventilatory parameters adjusted to maintain adequate oxygenation? When we want to improve the oxygenation of the patient, what should be adjusted? What should be your initial response? What are the changes in the ventilator done? We adjust the PEEP and FiO2, or we adjust PEEP and respiratory rate, or we adjust respiratory rate and tidal volume, or we adjust FiO2 and tidal volume. If you respond, then I'll be able to.
Sinai has typed A, PEEP and FiO2.
Very good. Beautiful. So the first initial response is, whenever the patient desaturates or there is any problem in the oxygenation, the initial response should be to increase the oxygen that is going to the patient. And then we also adjust the PEEP. So in order to adjust the minute ventilation, we adjust the respiratory rate in ARDS patients. Because we are giving low tidal volume, we keep the respiratory rate maximum up to 35. So two things we need to adjust: tidal volume and respiratory rate. And if we want to improve oxygenation, then we adjust PEEP and FiO2. The simplest maneuver is to immediately increase the FiO2 so that it increases the PaO2. But I've told you, long term, we do not want to give 100% oxygen. Our aim should be to bring it down to 60% as quickly as possible. Because there is shunting of blood. The lung is not, there is blood flow outside it, but the lung parenchyma, it is filled with something, either water or blood or pus. So it is not getting the oxygenation. So we want to give the oxygen which is in the blood. We will increase by giving FiO2, and we'll open these alveoli which are collapsed by applying the PEEP. So they will keep the alveoli open and they will allow the gas exchange to occur even during expiration. They will prevent the repeated opening and closing. So these two things will help us in improving the oxygenation. So modes of ventilation, there are variety of modes, which are conventional modes, newer modes, smart modes. As you go in the market, you want to buy something, you have a variety. So these many modes are available in the market, but you should use the mode which you understand and it is, because no mode is better for the patient. Where you can monitor the patient best is the best mode, because what we want is the patient safety, patient comfort, and early liberation from the ventilator. So two things which describe the ventilatory mode are the control variables and the level of support. So in a ventilator, if you are giving a set volume of air, that is a volume control mode, or if you have maintained a certain pressure, that becomes the pressure preset modes. So if volume is fixed, there are two things, volume and pressure. If you set a volume of air, it means the pressure in the airways will vary depending upon the characteristics of the lung. Or if you have fixed a certain pressure, then that certain pressure will generate your volume. So you should understand there are two things which we need to understand, that either they are volume preset modes or there are pressure preset modes. Now in the pressure preset mode, always these are called the graphics, which you can see in all ventilator nowadays will have these graphics. So if the pressure waveform is constant, it is not rising, it is a constant square waveform. A certain pressure is achieved and it is maintained. That becomes a pressure preset mode. In this mode, obviously we are giving some volume, so volume will increase, but the flow will be always a decreasing type of pattern it will have. But in a volume control mode, the flow will be fixed because we are blowing at we are giving gas at a particular flow, the pressures will be rising. So in volume control mode, you need to monitor the pressures, and in pressure control modes, you need to monitor that adequate volume is going to the lungs or not. I'll describe them in further slides. So we can think that lung is a balloon and we are blowing into it through the pipe. That pipe are the airways. So if I want to blow a 400 tidal volume into the lung, I will blow at 40 liters, 50 liters, some fixed flow I will blow. And if I blow at a fixed rate, I'm continuously blowing into the lung, into the balloon, the pressures will rise. So I blow constantly. You can think the ventilator is constantly giving some gas at rate of 50 liters till the pressures rise and the volume rise. When this volume 400 is delivered, the flow stops and the pressure drops. The patient goes into expiration. So that is simple method to describe the volume control mode. So any mode of ventilation, that depends volume or pressure and what kind of support. Either it is complete support or partial support. Complete support means all the breaths are being taken by the patient. Assisted means the patient is initiating the breath and the ventilator takes over. And spontaneous means patient is only taking the breath. Nowadays, it is wrong. CMV, that is controlled mandatory ventilation, is usually not there because it is wrong that the patient wants a breath and the ventilator is not opening and giving the breath. So most of the ventilators now have assist mode incorporated. Either it is volume assist or pressure assist. It means the patient will trigger, but the complete breath will go to the patient by the ventilator. Only the triggering part, the initiation of the ventilation will be done by the patient. That becomes an assisted mode of ventilation. So volume preset can be volume control, volume assist or SIMV. They are volume preset, and pressure preset include pressure support and pressure control mode of ventilation. Again, I am showing that in volume control, flow will be constant. If flow is a square graph, you know it is volume preset modes. If pressure is a square wave graph, these are pressure preset modes. So how do you set a volume control mode? So this is a ventilator screen. When I want to set a volume control mode, I will define a particular volume which I want to give. Like I want to give 380 tidal volume. How many times? I will have to set the respiratory rate. I have talked about, you set it at physiological 12, 15, 18. A PEEP of 5. What oxygen concentration? This means FiO2. You can increase it to 100%. IE ratio 1:2. Now we have to worry because whatever is the pathology, if this tidal volume is not being delivered, I've set 380 tidal volume should be given 18 times to the patient, and the graph should come down to, and during expiration, PEEP will be 5. So I have to set the P high or the P alarm limit, because when the gas is going, if there is some problem, the pressures will rise because I have fixed that 380 tidal volume must go. So when the patient is put on volume control mode, pressures have to be monitored. So this is the graphic representation. What you see, like see here, inspiratory valve is open, gases are going to the patient. So the flow is going, so pressures will rise. When both these valves close down, this is inspiratory pause, this is the pressure. So sometimes we see peak pressure increased. So this pressure is increased if this tidal volume 380 is increased. So it means there is something which is blocking this tidal volume to go from into the patient. So you need to check where is the problem. And what will happen during expiration? The expiratory valve will open and the pressures in the circuit will drop. So this is the classic graph which you will see on the screen of a patient of volume control mode. When the inspiration begins, the pressure will rise. Then when both the valves close, the pressure will fall to a pressure which is called the alveolar pressure. And when there is expiration, the graph will fall. So volume will also increase because we are set this tidal volume, and the pressures will also have this curve linear graph. So again, here this is volume control and volume assist. There is just a difference. That is, here the pressure is dropping. The patient is initiating the breath. Here it is the patient is not initiating. It is going on a time basis. So you need to understand that only that when the flow is constant, pressure is increasing. It is a volume control mode of ventilation. So sometimes you see that the peak pressures are very high. The ventilator is giving an alarm. The 380 tidal volume is going, but the pressure which we have set a peak pressure of 40 or 35, the pressure is going high. So there are various things you come to know. If the peak pressure is high, but the plateau pressure is low. So there is a lot of difference. This plateau pressure is coming 25, but here it is coming 45. So this difference is very high. So there is increased resistance. There is somewhere a block, either a mucus plug, or there is patient is bronchospasm, the endotracheal tube is blocked, patient is biting, anything can happen. On the other side, if the peak pressure is high, but the plateau is also high, this plateau is 36 and the peak pressure is 40. So that means this lung is bad. It needs more pressure to inflate. So it may be ARDS, it may be pulmonary edema, or it may be pneumothorax. So if the peak is high, the plateau is not high, there is something which is increasing. There is a block somewhere. If plateau and peak both are high, it means there is some problem in the lung. Now coming to the second mode, which are pressure targeted mode. Here we see we have a preset pressure. When I want to blow into the lungs, like I explained, the volume control mode, when I'm blowing into the lung at a constant pressure and I don't want the pressure to rise, so it means my flow will have a decelerating part. So here is a graph to show you. In this graph we see we are not setting the tidal volume anywhere. What we are setting is inspiratory pressure and inspiratory time. So 15 pressure will go for 0.48 seconds. 29 is the respiratory rate. So it is set 29. So this many times this will happen. Pressure will go to 24. It will come back to 6. It will go to, we can see peak inspiratory pressure 24 and come back to 6, 30 times in a minute. But there will be no tidal volume I have set. So we have to be very cautious and monitor the minute ventilation, because if there is a block, the pressure will not rise. What will happen? The volume will not be delivered. So when we are setting pressure set modes, we need to monitor the tidal volume of the patient. This is just a comparison of both the modes. So this is what is CPAP. Normal pressure breathing, I told you, is negative pressure breathing. When you give a positive pressure, that your normal breathing occurs at a particular pressure, the expiratory pressure is always positive. So that becomes CPAP. But we add pressure support to this CPAP. That is, patient initiates and the pressure is also added so that the tidal volume increases. That becomes your CPAP plus pressure support. So when the nurses are the one who are at the bedside, and if there is any problem, they are the first one to respond. So your intention should be to assess the patient whenever there is a problem with the ventilator and then look at the ventilator. So if there is a alarm on the ventilator, assess the airway. We will go ABCD. Assess the airway. Like, is the airway patent? Isn't the tube is not blocked? You listen. The tube has not come out. There are no sounds which are coming. The chest is rising and falling. The tube is secure at its proper point. The patient is breathing. What is his saturation? What is his end tidal volume? What is the monitor showing the tidal volume? The tidal volume is being delivered or not. Look at the circulation. The patient is pink. He's not become blue. He's having the heart rate has not fallen. What is his ECG? What is his rhythm? What is his blood pressure? What is his level of consciousness? If the tube is blocked or tube is dislodged, or what is his response, and what are the patient's environment? You have to take care of the dignity of the patient. So your first, any problem comes, the first response is by the staff. So you system wise, you start checking that the airway, first the airway is intact, then the machine is delivering, the proper breath is being delivered, and what is about the, if it is being delivered, so what is the oxygenation status or the circulation level, and then look at the disability. So alarm limits should be adjusted in the way to reduce unnecessary noise, but within the same limits. And these are the most important alarms: high pressure alarm, low pressure alarm, minimum minute ventilation alarm, apnea, and backup ventilation. So which is not a cause of high airway pressure alarm? There are high pressure and low pressure alarms. Which of them is not a cause of high airway pressure? Attempts to speak, biting, bronchospasm, disconnection, or secretions. This is an easy one.
So one of them has type disconnection of the ventilator circuit.
Very good. So all disconnection will give us a low pressure alarm. By remaining else, they will prevent the breath from going towards the patient and cause a high pressure alarm. So a low pressure alarm means resistance to the inspiratory flow is less than what is required. So that happens when there is disconnection or leak in the circuit. High pressure alarm comes when there is the pressure which is required is more than what you have set. So if there is a pneumothorax, if there are excessive secretions, if lung compliance has decreased like in an ARDS patient, if the patient is restless, he's biting on the tube, there is water in the circuit, all these things will be called a high pressure alarm. I told you we have to be very cautious about minute ventilation alarm when the patient is on pressure control mode of ventilation, because there the pressure will not rise. You have set a fixed pressure, but if the tube gets blocked and the patient is on pressure control mode of ventilation, the tidal volume will not be delivered. Pressure to set kar diya 15, 18, it will not rise, but the volume is not delivered. So minute ventilation will be low. Or if there is a leak, again minute ventilation will be low. So I have seen a patient going into respiratory arrest, peri-arrest condition, almost cardiac arrest, because the minute ventilation alarm went unnoticed. Now, when we wean the patient, we put the patient on CPAP. We do not give any tidal volume. We do not adjust any respiratory rate. We give only pressure support, and that is determined. The rate and the tidal volume are determined by the patient. So apnea alarm must be set when there is CPAP. Backup ventilation must be set. So if patient is fatigued or over sedated due to medication, then apnea alarm will come. And FiO2, we know if there's a disconnection or leak, FiO2 will also give. So these are the most important alarms. Pressure alarms, very important for volume control, and no minute ventilation, very important when the patient is on pressure support. And apnea alarm, most important when the patient is on CPAP mode of ventilation. So which is the most appropriate intervention for a patient whose ventilatory alarms on account of patient not receiving adequate tidal volume? So you've set an adequate tidal volume and the patient is not receiving. So which is the most appropriate intervention? What will you do the first? Suction the tube, check the cuff pressure for leak, ensure ventilator is connected to the patient, ensure patency of the endotracheal tube. So if the patient is not getting the set tidal volume, the most any answers?
No answers till now.
So most common thing when the patient is not getting, when you get a low minute ventilation, MVE, low expired minute ventilation is low. When you get that alarm on the ventilator, the most common thing is a leak. So ensure the ventilator is connected. You do suction, you reconnect the thing. Sometimes the connection is loose. Sometimes the port where you have done the suction is open, or some connection is loose. So there is a leak in the circuit. So first of all, ensure that this, or you can, there may be a cuff leak also. So B and C could have both have been the answers in this. So whenever there is an alarm, don't panic, but don't ignore. Don't ask the patient's attendants to silence the alarm. That is the worst thing that anybody can do. Don't mute the alarm. Just remove the patient from the ventilator, because if the alarm is giving and the patient is not fine, you have checked the ABCD. If you take the patient immediately on veins and you ventilate, the first thing you have come to know that the patient is all right, the problem is in the machine. Because if you ventilate and there is chest rise, the tube is patent, the lung are getting ventilated. So remove the patient from the ventilator, initiate manual ventilation by connecting other means of ventilator like a Baines or an ambu bag, perform a primary survey, assess the monitoring indices, like I told you, check the saturation, check the heart rate, check the bilateral air entry, the chest rise of the patient. And once the patient is stabilized, then do a more detailed examination, call somebody for help. So first thing, whenever there's an alarm and you don't know what to, something is happening, disconnect the patient from the ventilator and take it on veins. If there is a tube block, you'll not be able to ventilate. You will immediately come to know what is the problem happening. Or the tube has got dislodged. You will hear the sound of the air bubble, gas leak. So you will come to know the tube is dislodged. So by taking the patient on the veins or the ambu bag, 50% of the problem, either problem is in the machine or here with the patient's airway, you come to know when you take this initial step. So stabilize your endotracheal tube properly. For males, it is usually done between 21 to 23, and for females, 19 to 21. Secure it properly to prevent any dislodgements, and check for cuff pressures to prevent injury to the trachea and also for leaks. So last, ventilation is not going to alone improve the patient. It is wholesome treatment, together all the treatment. But when the patient is on ventilator, you must take care that he does not get any infection, which is called ventilator associated pneumonia. And these are the components of the VAP bundle. DVT prophylaxis must go on, ulcer prophylaxis, head end should be elevated, and sedation, vacation, and weaning. And this we all know, fast heartbeat we are doing, because that are very important essentials for the care of a patient on the ventilator. So use the mode of ventilation which you are familiar. You must remember, if patient is on volume control, the pressure will vary and you have to monitor the pressures, peak pressure alarms or low pressure alarms. If the patient is on pressure mode, you have to be very vigilant to monitor the minute ventilation alarms. I think I should finish. The 10 minutes left. We will do some questions if there are any.
Thank you very much, ma'am, for such an elaborate discussion. And now the house is open for questions. So you can type your questions in the chat box and we can discuss. Because it's a very relevant topic, and if you have any doubt, you can clear it in this forum.
So most common modes are used, either volume control mode or the pressure control modes. So that is why I focused only on these, and you just need to understand, in volume control mode, a fixed volume is going to the patient. If the patient has any problem in the lungs, the pressure are going to vary. So the peak pressure will rise and the volume will not be delivered. So monitoring of the pressure alarm, or if there is a disconnection anywhere, leak anywhere, the low pressure alarms will come. And similarly in pressure control, because we are saying pressure control, the pressure will always be controlled. It will never rise. So if there is a problem that idle volume is leaking, or there is any resistance, the tube is blocked, the pressure will not rise, the volume will not go. The patient will start retaining carbon dioxide, will go into hypoxia, but the pressure alarm will not come. The only alarm that will come will minute ventilation low. So all these problems will be solved the moment you take the patient on Baines or ambu bag.
So any questions you can type in the chat box. Like in modern medicine, we always practice do no harm. So whenever we are setting the patient on ventilator, we should always see what are the settings on the ventilator. Like tidal volume, ma'am said that it should be 6 to 6 ml per kg. Then what is the PEEP level, FiO2 level? So we should all keep a check on that. What are the settings of my patient? What are the settings of ventilator on my patient? And sometimes patients are on support mode and we just shift the patient to the previous mode. So when we are shifting the patient to previous mode, we should again see the settings. Because sometimes what happens is that tidal volumes are not set properly or PEEP is not set properly. Because you see that mechanical ventilation is a supportive therapy, but it's not without the harm. It can lead to various side effects, right? It can lead to hypotension, barotrauma. So whenever we are setting the patient on ventilator, the parameters, the most important parameters are FiO2, PEEP, tidal volume, and respiratory rate. And another thing is that we should see what is the mode of ventilator, whether it is pressure control or volume control.
Another thing on the mechanical ventilator, when we are putting the patient on volume control mode, the peak which comes on the side, that is, if you have set it on 40 or 30, that is the limit. It is not कि patient की pressure support itni hai. Sometimes I've seen sisters charting that as pressure support. That is not pressure support. That is peak. We do not want the limit should go 40. That is only the limit that if it goes beyond 40, the volume will not be delivered. So the ventilator tries to protect. That is, if we have set a peak of 40 and the patient bucks on the tube, the pressure rises above 40. So when it reaches 40, the tidal volume, whichever has gone, will go to the patient. The remaining will not go to the patient. Like you can see, it is an exhaust valve of your pressure cooker. That valve will open and the remaining gas will not go to the patient. The ventilator wants to prevent any harm, but it will raise the peak alarm so that you come to know patient is bucking or the tube has blocked. So that P alarm 40 is not set to give anything to the patient. That is just a safety limit which is set.
And never ignore the alarm. Like what
Yes.
happens is that our first reaction is to just mute the alarm. So whenever there is an alarm, just try to see what is the alarm. If it is a low pressure alarm or high pressure alarm or what is, so then you have to manage appropriately because these alarms are for patient safety. And if we will ignore the alarm, then this can lead to dangerous consequences.
And never hesitate in calling for help.
Yes. So any query, you can just write it on the chat box and we can discuss. No, what are the weaning modes? Like, will you like to discuss? Like you discuss pressure control, volume control. So what is the weaning mode which you use in your ICU?
Yes, we can put the patient on, there is no harm for a patient who is post-op coming to you. You put the patient on SIMV mode, that is sometimes used as a weaning mode. You might put that is synchronized intermittent mandatory ventilation that allows your patient to take some synchronized breath. But once you see that the patient has started inhaling, the best thing is to put the patient on CPAP with pressure support.
So nowadays, pressure support is the most common mode which is
Yes,
used for weaning.
most commonly CPAP mode is used, and there is SBT trials within the ventilator sometimes. So you can initiate that also by putting pressure support on the ventilator. But the most important thing is whenever you put the patient on CPAP, first few initial minutes, you have to be at the bedside of the patient. And it is not only that the patient tidal volume, but the hemodynamics have to be monitored. When you put the patient on CPAP, you must see any change. Patient is having bradycardia, tachycardia, hypertension can also occur. Any change in the vital signs, desaturation, you must immediately inform and take the patient back on this. So initial few minutes while you take the patient on CPAP are very important for monitoring both respiratory parameters as well as hemodynamics.
A very important point, ma'am said that when patient is not being ventilated, you just take the patient on veins. Because sometimes what happens is that problem is in ventilator also. There can be a mechanical issue with the ventilator. There can be a problem in the HME which we use, or in the cassette, ventilator cassette. So when you use put the patient on mains, then you remove all these obstructions, and then you can see what is the problem in that case. So there is no need to panic when you see the patient is not ventilated. If it is in situ, if endotracheal tubotracheostomy is in place, then you can easily take the patient on mains and ventilate with the mains, and then try to find out that what is the cause of the that patient is not being ventilated. Either they have understood everything.
This slide, I don't know how I slipped. See, this is the CPAP mode of ventilation. When we try to put the patient on CPAP, we have not set anything, tidal volume or respiratory rate. We just set PEEP and we set pressure support. So patient takes his breath on his own. So this is the weaning mode we use nowadays, that we set the level of pressure support. I have set here 5, 8, 10, whatever you set, so that he achieves an adequate tidal volume, which you were giving on VCV mode. That tidal volume is achieved and the patient has his own respiratory. He is generating his own breath, his own tidal volume with this pressure support. Nothing is set. See, in these parameters, we've set only the FiO2, PEEP and pressure support. So no rate, no voluming is being set when we put the patient on CPAP. It is a weaning mode and all breaths are initiated and triggered by the patient.
Another important thing is that when you are putting the patient on pressure support, one thing is that patient underlying disease should have resolved. Patient should be out of sedatives, like he should be hemodynamically stable. So whenever you are putting the patient on mechanical ventilator, you have to see whether patient is fit or eligible to be put on weaning mode, because in pressure support, as there is no backup rate, so all the efforts will be generated by patient. All the respiration has to be taken up by the patient. So patient can get tired. So before putting the patient on weaning, you have to see the eligibility, whether they can be weaned or not. And then they require more careful observation than the control modes.
I think we can end this session.
Yes, ma'am.
Thank you.
Thank you, Dr. Gunchan, for such an elaborate discussion. And it's a very complex topic, but you presented it in a very lucid way. Thank you, ma'am. And
thank you so much.
Thank you.